We differentiated between various bone and joint infection and listed common microorganisms associated with vertebral osteomyelitis or prosthetic joint infections. We selected effective drug therapy for treatment of bone and joint infections. Now, let's avoid drugs that lack bone penetration for treatment of osteomyelitis. In general, oral beta-lactams have low bioavailability and should not be prescribed for the initial treatment of native vertebral osteomyelitis. Also, oral vancomycin is not absorbed and therefore it should not be used to treat any systemic infection. The only time oral vancomycin is indicated is for C. diff infection or Clostridioides difficile infection, which is in the GI tract. Now, on the other hand, antibiotics that have excellent bioavailability include fluoroquinolones such as ciprofloxacin, levofloxacin, and moxifloxacin, as well as linezolid and metronidazole. And these allow the possibility of early switch to the oral route without compromising efficacy. Here's a list of drugs that are excellent oral options because of their excellent oral bioavailability. Metronidazole is specifically used when there is osteomyelitis due to Bacteroides. So Bacteroides are anaerobic organisms. Moxifloxacin is not indicated for staphylococcal NVO, but it can be used for Enterobacterales. Linezolid is an excellent PO option for MRSA NVO. Levofloxacin is also used for Enterobacterales, and ciprofloxacin is excellent for pseudomonal infections. Bactrim or trimsulfa is not recommended for staphylococcal NVO, but it can be used as second line for Enterobacterales, and clindamycin is considered second line choice for staphylococcal NVO. And as I mentioned previously, for brucellar NVO, the combination of doxycycline and rifampin is an excellent oral option. Here you can compare different antibiotics and what percentage of the dose will actually penetrate the bone. There's no magic number of what percentage would be ideal because these antibiotics are given at different doses, so these percentages are not really comparable, but it kind of gives you a sense of how much of the dose that's given to the patient actually makes it to the bone. Now, ceftriaxone, it's really important to keep in mind that the usual dose of ceftriaxone is 1 gram once a day. Because of its poor bone penetration, typically less than 20% of it gets to the bone, so it is recommended to use a higher dose of 2 gram once a day when it comes to osteomyelitis. Now, some of these agents like daptomycin may seem like they are a poor option for osteomyelitis, but considering that we give a very large dose of these antibiotics like daptomycin, even that small percentage that gets to the bone is going to be a huge concentration of daptomycin. So everything listed in this table is actually an excellent option for treatment of bone and joint infection. Now, keep in mind that the dosing that's recommended by the guideline for inpatient, and compare that for outpatient. So if the patients require weeks of antibiotics, they're not going to stay in the hospital for 4 to 6 weeks, so they actually can go home on some of these IV agents. And you will see that, for example, if a drug is given, several times a day, one way to convert that into a once a day dosing is to give a continuous infusion. So what continuous infusion or CI means is that you will give the entire dose for the entire day. You basically infuse it over a 24-hour period. So you basically change the bag every 24 hours. So by doing this strategy, you achieve two things. One thing is that for beta-lactams specifically, because they are time dependent, you maximize the time above MIC. And the second thing is that you essentially convert this regimen into a once a day dosing, and that makes it easier for outpatient management. It is also important to note that ampicillin as well as carbapenems, basically meropenem, imipenem, doripenem, these drugs are not suitable for outpatient continuous infusion because of their short stability. So meropenem, imipenem, doripenem, these drugs typically are stable for 4 hours. So if you were to do continuous infusion over 24 hours, basically the bags needs to be changed every 3 to 4 hours, which makes it extremely difficult to do continuous infusion. Even in patient, it's very challenging to give carbapenems as a continuous infusion. Erdapenem, of course, is an exception because it's actually dosed once a day. So it's really not necessary to convert it to continuous infusion because it's similar to ceftriaxone, is dosed once a day. So it's really convenient for outpatient. So here you can see that it's recommended to avoid carbapenems other than erdapenem for outpatient if possible because of stability issues.